So to the fellows for sure, if you don't know Rick Sasso, you should. He is a stalwart of spine surgery. He's been a foundational scientific sort of godfather of certainly cervical and much of spine surgery as long as I've been involved in it. And he's one of those go-to guys in terms of being a thinker and understanding what we do on a practical side as well as on an evidence-based side. And really in the world of cervical disc arthroplasty, I would rely on no one more than Rick to give me guidance when my perception is there's a little gray out there. So without further ado, Rick, take it from there.
Thank you. That was the best introduction anyone could ever give me. So I am I'm trying to share my content. How do I do this?
Be a share.
Yeah, do you see a box with an arrow?
I see it, but I don't see my. Huh. Well, okay, so I have a bunch of, I've never seen this before. Oh, browse my computer. Is that it?
You should have a few options. Browse your computer, which windows to share. If you select which window to share, you can just select the Microsoft, the PowerPoint.
But is it giving you the share option even? That happened where it did not.
Look like much is happening, is it?
Oh, there you go. Just did something. Yep, you're on.
Yep.
Okay, you guys can see that. So, you know, I've given this over the last, I don't know, couple years, and I thought maybe you guys would get bored with this. So, I'm going to give you a little extra today. So, I want to present to you something that's not been presented to any audience up to this point. It's actually going to be presented at ISASS. Dr. Eastlack and I were just talking about ISASS. It's going to be presented at ISASS and European CSRS in 2 weeks. This is the first 20-year follow-up of a prospective randomized controlled trial of cervical disc arthroplasty. And all right, so tell me, how do I'm not seeing how to get, okay, all right, I guess that's it. So this is 47 patients done 20 years ago. So 21 years ago, actually this month, 21 years ago, I did the first cervical disc replacement in the US. And over the last year, we've tracked down these patients that were in the initial FDA IDE trial from my site. We had 24 randomized to arthroplasty, 23 to ACDF. We had 3 patients cross over from arthroplasty to ACDF due to some technical issues, intraoperative technical difficulty, and we'll talk about some of that, those technical issues in my tips and pearls section in just a second. What I'm most proud about, though, is our follow-up rate. Over 89% follow-up rate at 20 years, which is remarkable. I actually had a fellow who's half CSI, half CIA. He was amazing. He tracked down all these people. You know, 20 years ago, most people had phones, home phones. No one has a home phone anymore, right? So they're all cell phones. So I tell you that following people out to 20 years is difficult and hard, and that's why it's really unusual to have a follow-up rate this high at 20 years. But what we found with this level 1 trial is that there was statistically significant differences in all patient-reported outcomes at 20 years in both groups, ACDF and the arthroplasty. However, there was not a significant difference between groups at 20 years. And here's your NDA VAS arm, VAS neck. So although the arthroplasty was better at 20 years, there was no statistical difference between the groups at 20 years. Looking at reoperation, though. So what's interesting, so we call freedom from reoperation. We had some patients that we couldn't find at 20 years, but we had at 10 years. And if they had a reoperation, we actually were able to carry those forward. And so we actually had, looking at the reoperation rate, mid 90% follow-up in both these groups. What is amazing is that the target level, we had no reoperations in the arthroplasty group. We had one in the ACDF group, which is a symptomatic pseudoarthrosis that had a posterior cervical fusion to repair that. In the arthroplasty group, we had one adjacent level reoperation at 20 years and one non-adjacent level reoperation at 20 years. So a 10% reoperation rate compared to a over 40% reoperation rate in the ACF group. So that is statistically significant. And what's interesting, at 10 years, although there were more reoperations than the fusion group, it was not statistically significant. But now at 20 years, there is a statistically significant difference in reoperation rate. So what we found was there was significant improvement at 20 years in both groups. And I don't know of any other medical procedure, medical intervention that has this good sustained improvement in outcomes at 2 decades. And despite having a higher reoperation rate in the fusion group, there was no difference in patient-reported outcomes at 20 years. Again, what is amazing to me is when you look at survival, construct implant survival, in the arthroplasty group, 100% survival at 20 years. In the ACDF group, if you consider it symptomatic pseudoarthrosis, that was the only reoperation we had at the target level. There was a higher reoperation rate statistically in the fusion group, over 40% versus 10%, adjacent level 5% versus 30%, and non-adjacent. We don't talk about this very much. The non-adjacent, so not adjacent level to the target, but at other levels. We found 5% in the arthroplasty and over 15% in the fusion. So just some interesting data at 20 years, and you'll see this being presented over the next few months at various venues. So tips and pearls, what I've learned over 20 years in a big, large chested, short-necked men, it's hard at C6-7. Here, a classic example of a big guy, you can't even see C5-6, much less 6-7. And in my opinion, you absolutely have to see the back of the disc space to safely place a cervical arthroplasty. Whereas if you're doing a fusion, you don't need to see the back on radiographs, but in an arthroplasty, you absolutely have to. So what we're going to talk about, tips and pearls, basically how I look at arthroplasty differently than fusions. Also, avoid placing an artificial disc in a deformity, whether it's at the apex of the deformity or even away from the apex of the deformity. You're not going to be happy over the rest of your career looking at an arthroplasty in a patient who has a cervical deformity. Also, avoid arthroplasty, what I call bone formers, patients that lay down a lot of bone. I'm going to show you this case that I did a couple of years ago. So the patient had a C6 radiculopathy. So this was the target level. Although there's this big anterior osteophyte at C4-5, I thought we may be able to do this. He was actually accepted for the Bagheera FDA IDE trial, and everything went great. He got rid of his radiculopathy, but 2 years later, you see he developed a myelopathy due to bone forming posteriorly at the facet region at this level. So again, in patients who are genetically predisposed to laying down bone, be wary of doing a cervical disc replacement. Also, adjacent to a multi-level fusion, although adjacent to a one-level fusion, I think the data is very strong. Adjacent to a multi-level fusion, I believe the stresses are just too much at those levels to consistently have success with your arthroplasty. All right, I'm going to talk about how I look at arthroplasty differently than a fusion in regards to how I position the patient on the operating table, how I define the midline, how important that is, how I place my cast bar distractor pins, and how super important it is when we're doing an arthroplasty. the role of PLL resection, how to prevent heterotopic ossification, and then we're going to have just a bit of discussion on end plate preparation and how important it is for an arthroplasty. So when most of us do ACDF, we place a towel or a roll underneath the shoulders. How I do this differently in an arthroplasty is the roll actually goes underneath the neck, underneath the cervical spine. You do not want to hyperextend the cervical spine. Although when we're doing infusion, the exposure is easier if the chin is out of the way of our corridor to the cervical spine. But we do not want to hyperlordose when we're placing an artificial disc. The problem is, if in a hyperlordotic segment, we tend to remove too much of the posterior end plate. And what that can cause then is the shells posteriorly to cavitate, relatively cavitate in the vertebral bodies, and then we have shell kyphosis. And this is a big problem early on in our experience with artificial discs. So we don't want to hyperlordose. We want basically the back of the head to be on the same level as the back of the shoulders. So we do not want to elevate the shoulders. We want the cervical spine in a normal lordotic position and not hyperlordotic. Also, defining the midline is super important, and I'll tell you, I do not use X-rays. I've been fooled with X-rays so many times, and you can make an AP X-ray look however you want. So actually what I use is anatomic landmarks. What I use is the longus colli. Because most of these patients have relatively normal anterior cervical anatomy, not a lot of osteophytes, the longus colli are actually very, very reproducible. And so I look at the longus colli, and the first mark I put with a bovie is a midline mark from the level above down to the target level and from the level just below to the target level. And I mark my midline based on the longus colli. Basically look at the longus colli like goalposts. I'm going to kick a field goal through the goalpost, and that's the mark I make. And that is, in my opinion, the most reproducible way of finding the midline. And actually on X-rays, I don't use the spinous process. I look at the uncovertebral joint. So I do get one X-ray, one AP X-ray at the end of the operation to look at my implant, and I'm looking at the uncovertebral joints. The spinous process, because of variances on how the posterior spinous process can be, that many times it is asymmetric and off the midline. So what is most reproducible is looking at the uncovertebral joints. And then I place my Caspar distractor pins. You want to be as far away from the target level as possible on that midline bovie mark. And what I do is I place the distal one first, because that is the best sort of way to assess the slope of the disc space is the cephalad end plate of the caudal vertebra. That is the most reliable in looking at the sagittal alignment of the disc space. So I place the distal one first, and then place the cephalad Caspar distractor pin parallel to that pin. Many of these distractor pins have these caps that you can keep the distractor from moving cephalad on the pins. I stopped using these long ago because although it keeps the distractor on the pins, the problem is that the forces then are then placed onto the pins, and so the pins can pull out. So I'd rather reposition my distractor back on the pins as it walks up it, rather than having the pins plow through the vertebral body. Also, when I'm doing infusion, I actually use the Caspar distractor pins to distract off of, to get my distraction. Doing an arthroplasty, I actually use more of intradiscal distraction, then keep the distraction with the pins. I want to really not stress these pins very much at all. Also, super important to take the PLL. Really important that and I don't know why this is not working. So that should be a video that shows taking the PLL. Sorry about that. I'm struggling here. But anyway, when I'm doing an ACDF, I take the PLL on the symptomatic side, but not on the contralateral side, usually. But because the patients can genetically sort of have this predisposition to calcify their PLL, it's important that you take the PLL on both sides all the way across. And I use 2 weeks of non-steroidal anti-inflammatory medication of their choice to decrease heterotopic ossification, like you can see right here. That's has been shown to decrease the incidence of HO. Also, a bit about end plate preparation. So what is so important is to have a level foundation to place your arthroplasty. And the cephalad end plate of the caudal vertebra is not flat. It's elliptical. It's like a football because of the uncovertebral joints. And it's so important to make this flat. And many times there are osteophytes, especially along the medial aspect of the uncovertebral joint, that need to be flattened off. And it's so important that we do this, that we make this a flat surface for our end plate to sit. What you don't want to have is things like this. I can tell you exactly how this happened. Looking at this, I can tell you exactly what the surgeon did. The symptomatic side was over here. He did a very generous and a very good decompression of the nerve root, taking the uncovertebral joint. He left this on this side you see here. And then this, because this device just goes to where the least resistance is. When he placed this in, it preferentially opened up on the well decompressed side, closed down on the side that was asymmetric, and that's how these things look ugly. So what I use is a barrel burr. This burr basically smooth. It's not a cutting burr. It actually, the cutting flutes are opposite on how the burr spins. So it basically smooths the end plate. I use a small 5 mm barrel burr and smoothing the end plate. And this is a video again, just showing basically back and forth, medial lateral to basically take away and flatten out the medial uncovertebral joints. So in my opinion, most favorable patient for an arthroplasty are those patients that have single level pathology, focal disc herniation causing unilateral radiculopathy in a young patient with normal facet joints and no significant degenerative changes above and below. If you use these inclusion criteria, the FDA IDE trials tell us that you're going to have a very, very good outcome. And these patients out to 20 years, as I showed you, have a very, very high rate of doing well. So thank you again so much for your time and attention. And I'm happy to take any questions, anything you guys want to talk about. That'd be great. If I can stop sharing. There we go.
So I'll start, Rick. While Cam and Amber and the other folks are thinking of questions. Given that the IDE trials have been very constrained in the indications, how have you personally either kept to those or kind of widened the spectrum of patients that you'll choose to operate on?
Yeah, so I am very conservative, whereas especially in Southern California, there are a lot of expanded indications for arthroplasty.
Yes.
And I showed you a case where I expanded my indications a bit, and I'm sad that I did. Even though that patient, that was an FDA IDE trial. That was the Bagheera IDE trial when you were involved in that. That include, even though that disc was pretty collapsed and there were some significant degenerative changes, they were allowed into that FDA trial. That, I will tell you, the original one, that probably would have been excluded. I know for sure would have been excluded. And I am sad that I enrolled that patient in an arthroplasty because of what you saw there. And I'm concerned that, yeah, in short term, patients do great. You can make their radiculopathy go away. But the problem is if you follow these patients for a long period of time, my concern is exactly what you saw there. That took 2.5 years for that stenosis, those bone spurs to reform, and now the patient has a myelopathy.
Right.
The concern.
So are you sticking to the 50% height loss and
Yes.
yeah. Okay.
No facet changes. The facets have to be pristine, and they have to have less than 50% loss of the disc space height.
That's what we teach these guys, but boy, that they're, as you said, in Southern California, that it's unbelievable how prevalent they are put in. Really is almost a default. More
It is.
than
And
ACDF.
you know what's so funny about it? Everyone wants it expanding. Okay, I get it, but show me the data. Show me long-term outcome in those patients, because at this point, I've not seen it. I've seen recovery room X-rays that, yeah, it look good, but show me the long-term outcome.
One of the other questions, and this came from some of the early work with the disc arthroplasties, was this concern about bony work and how much bone resection you do, creating more risk for HO. So how do you find that balance when you're smoothing out the uncovertebral joints medially, feeling like you're not overexposing bone that can behave that way?
I don't think that's an issue. I'm going to tell you just sort of my experience. Early on, the brine disc was sort of maligned because of the milling that you had to do, and there was some European data. In fact, the front cover of Neurosurgery showed a brine disc wrapped up in HO all over it. I mean, and the Europeans had a very high incidence of HO, and one of the first discs was a brine disc. So John Heller went over and looked at Jan Goffin's data and found that those patients that had non-steroidals had much less HO postoperatively. So we started the first arthroplasty FDA ID trial was brine disc, and we enrolled all the patients with 2 weeks of non-steroidals postoperatively. We had an incredibly small, low incidence of HO, despite the fact that we did milling. And part of that 20-year follow-up that I just showed you, we're actually now looking at all the X-rays, the radiographs at 20 years, and doing a lot of measurements, looking at things like HO, adjacent level changes. And I will tell you, at 20 years, we have a remarkably low, just like at our 2-year follow-up, remarkably low incidence of HO, despite milling the end plates. And if you look at some of the other discs, had a very, very high, especially ProDisc C, super high incidence of HO, and they did not use non-steroidals routinely postoperatively. So I think it's a little more complicated than it's bone dust. I use that technique of smoothing that cephalad end plate of the caudal vertebra. Every single time I put an arthroplasty in, there is dust that's generated from that, but I think it's really important to make a flat platform for my arthroplasty to sit on. And I've not noticed a significant increase in HO by doing that. I don't think my incidence of HO is any higher than anybody else's.
Very good. Any are you using any particular NSAID? Using the total joint arthroplasty?
I let them pick their, if they have one, but if they don't have one, I just tell them to leave, over the counter leave, 2 of them twice a day. 2 twice a day for 2 weeks.
What about those patients that can't take them? What do you do for them? Do you not do an arthroplasty, or you just take the risk?
It's a good, you mean because of like GI things?
Yeah, GI or the cardiac
allergies.
data that's out now,
Yeah,
I feel like patients are saying all the time they can't use them anymore.
Sometimes they can take Celebrex, especially if they have some GI issues, maybe prescription Celebrex, and sometimes some of the other issues that they may have, they may be able to take a selective. But if they can't, the cardiologist says don't take them, then I just have not take it. I mean, I think it's important, but I don't think it's critical.
Yeah. Okay.
Amber, any questions?
Yeah. Preoperatively, when you're assessing the facets, do you just use X-rays, or do you get any other advanced imaging?
I just use X-rays. In the original Brian IDE trial, we got CT scans on every patient, and we really looked at the facet changes. I don't see that it changed how I assess. I can assess at least I think I can, the facet joints on plain X-rays good enough. And if I see changes, osteophytes, significant narrowing of the facet joints, then I will exclude them. They have to look good on an X-ray.
What about the spondy patients? Do you just automatically go to fusion on them?
You mean if they have a slip, spondylolisthesis?
Yeah, if they have like a little grade 1 degenerative slip.
Yeah, I do not think that's a good indication for an arthroplasty.
Good.
You're going to be really sad. You'll be very sad.
Yeah, I want fellows to hear that. So that just means the motion's wrong at that level, right? So don't put in something that's going to preserve motion.
Right.
And the pathology kind of demands a fusion. So,
Rick, you've done a ton of different disc replacements and trials and otherwise. Do you have some sort of algorithm you use to decide what sort of constraints you want, or how are you choosing the device now based on biomechanics or imaging characteristics? What is your current modus?
That's a great question. So the short answer is I put in whatever FDA ID trial I'm doing right now. That's I mean, that's the reality.
Yeah.
But actually, what's so interesting, I'm giving a talk at ISAS, and I'm just putting it together right now on constrained versus non-constrained discs and how we should think about it. And frankly, we can get all into the kinematic, which I love. I love talking about the kinematics, but I will tell you, there is no difference. And when we look at our outcomes, our data, all these discs look different, but the outcomes are really good on all those that have made it through the FDA IDE process. What I will tell you, what you said at the end was imaging characteristics. I think probably what is just practically the most important issue, especially if you're dealing with a patient that may develop myelopathy, is don't put a cobalt chrome disc in. You're not going to be able to see the target level spinal cord. You're not going to be able to see it. And so there are some discs with really, really small footprints. The smallest footprint is actually Simplify, with the peak on ceramic, but also titanium and plates have much less footprint than the cobalt chromes. I really don't like putting a cobalt chrome disc in because of that inability to assess the neural structure, especially spinal cord, on an MRI.
Good deal. One other question: if you have a patient who remains symptomatic for whatever reason, neck pain, radicular symptoms, what's your typical imaging workup? What are you using to assess the disc apposition and other potential mechanical failures?
Other than X-rays, I want to look at their MRI scan. I mean, these operations I do for neurologic reasons, mostly radiculopathy, maybe a little bit of mild myelopathy, but vast majority, pure radiculopathy. So if they may not have, as we all know, may not have improvement of their neurologic symptoms. So I want an MRI scan to look at the neural structures. And if you look, especially the initial European data, the most common reason for failure was a radiculopathy on the contralateral side of the original symptoms because they didn't decompress the contralateral side. And, we get away with a lot of shitty neurologic decompression with a fusion. In fact, you don't really need to do a really good decompression if you're going to distract the disc space and use that segment, as long as the fusion takes. With motion preservation, though, we've got to be really, really good at neurologic decompression, not only on the symptomatic side, but also the asymptomatic side, because we may cause radiculopathy when we allow motion, and even more motion to occur.
Very good point.
So the answer is MRI scan. Now, if you use a cobalt chrome disc and you can't see the neural foramen or the canal, now you're stuck with CT myelogram, which I hate CT myelograms. I know a lot of people use them, but you have a 10% chance of giving them a horrible headache and all the issues of a myelogram, and then a lot of radiation with a CT scan. So
I totally agree. Well, I want to be respectful of your time, Rick. Thank you so much for imparting that wisdom for 30 minutes this morning.
Thanks again. It was super fun, and I really appreciate you guys inviting me to do this. Thank you.
It's been awesome.
Thanks,
Rick.